Assalamu alaikum and good evening, everybody. Today, we are going to have our a case studies, and today's case presenter will be Associate Professor Dr. Kaniz Fatema. She is Associate Professor of Critical Care Medicine, working in the BIRDEM, which is the premier institution for diabetes and other endocrine diseases. And she has extensive experience regarding the management of ICU patients. We are interested in her perspective in dealing with different situations where the cardiac issue is an important factor in determining the outcome of the ICU patients. And amongst our panelists, we have our guru, Dr. Rafiq Ahmed sir, and also Chowdhury Hafizul Hassan will be joining shortly. And also amongst the foreign specialist, Professor Arun Maski and Professor Sujip Bhandari has joined us. And from our national faculties, we have many more eminent cardiologists that all of us know, including Professor Atahar Ali, my co-partner and course director, Professor Mohsin Hussain, Professor Sardar Makaddas Hussain, Professor Abdul Jamil, Khandakar Asaduzzaman, and many more. I hope, as before, we all will be enjoying and enlightening ourselves from the case scenarios that will be bring forth by Dr. Kaniz Fatema. Kaniz, I hope, like the last time, we'll be enjoying again and again. And Rafiq sir is there to guide us again and again. Thank you, everybody.
Thank you, sir. Should I start now?
Yeah, you can share. You can start sharing.
Respected senior, my fellow and junior colleagues, Assalamu alaikum. I'm Dr. Kaniz Fatema. In the beginning, I'd like to again express my gratitude to Professor Abdul Wadud Chowdhury sir and Professor Atahar sir for inviting me in this panel. Previously, I have discussed two cases. Now, today I'll start from my case 3. A 42-year-old male who was diagnosed case of hypertension, dyslipidemia, presented in our intensive care unit with gradual loss of consciousness over 2 days. He was a businessman by profession and was a regular alcohol intaker. On query, his family gave history that 3 days previous to ICU admission, he had a party with his friend and there he had heavy alcohol intake. 1.5 days later, he had complained of dimness of vision and fell on ground. But family did not give importance to that. Then 1 day later, he became totally unconscious and was brought to our ICU. On admission, his ECG showed severe metabolic acidosis with respiratory acidosis. He had hyperkalemia, raised urea creatinine, raised CPK, and ultrasound showed grade 2 fatty liver. This was his ECG, which was done on admission. We can see that there is sinus tachycardia with incomplete right bundle branch block. Echocardiography was done by our cardiologist on next day, which showed anterior and there was suspicion of myocardial infarction. There was mild LV systolic dysfunction. Left ventricular ejection fraction was 40%. His troponin I, which was done on admission, was 0.19 nanogram per ml. The cutoff value was 0.06. After getting the echo report, which was done on the second day, we again repeat the troponin I. This time it was 1.37. And next day, we did the third sample, which was 0.36 nanogram per ml. As the patient had severe metabolic acidosis associated with visual abnormalities and CNS involvement, we treated him as a case of methanol poisoning. And in case of methanol poisoning, there is associated myocardial dysfunction due to methanol, and severe metabolic acidosis can also cause myocardial depression. There are several studies which showed that there are some ECG abnormalities like J-point elevation, QT prolongation, T-wave abnormalities, or ST abnormalities in case of patient with methanol poisoning. Around 5.3% of methanol toxicity patient may present with acute myocardial infarction. In our patient, we assume that this raised troponin I level may be due to methanol-induced myocarditis. Now, the next case, my next two cases are almost similar. The first one, a female patient, 67-year-old diabetic, hypertensive, asthmatic lady.
We can discuss a little bit about case 3.
Okay, sir.
Rafiq sir, can I ask you a question? When there is troponin I raised, but the patient do not have the typical background of ischemic chest pain history, should we be calling it non-STMI or should we be calling it cardiac injury?
Two issues. First of all, the ECG itself, there is not much. Even though it has been defined as, I don't think the cure is duration 100 milliseconds. So there is no acute change in the EKG to suggest myocardial ischemia. So next slide, please. The other question I have for you all is, can you show me the next slide? The echo diagnosis of anterior ischemia and myocardial infarction. The echocardiographic diagnosis of anterior ischemia and myocardial infarction. I don't do echo regularly, but Wadud, can you make that comment from a single echocardiogram?
One thing I would say, sir, from the echo, we should call what is the ejection fraction, whether there is any regional wall motion abnormality. But calling itself that only ischemia is very difficult because cardiac injury due to either septicemia or a toxin, they can also produce ischemic regional wall motion abnormalities. So in this case, when the ECG is not at all suggestive, I would rather go for descriptive description. The ejection fraction is like this, wall motion abnormality is like this.
Yes. So I think this is one point that when we were medical students, I mean, EKGs were rare, but when there was some ECG, some would say definitive ischemia from one single ECG. Same with echo, I think we should describe the finding. And if they correlate with the clinical picture, then at best we can make a comment, consider ischemia. But just by single EKG to call anterior ischemia is difficult. We don't do that here. Same with diagnosis of myocardial infarction. We can say suggest. So that's thank you. Now the troponin, of course, is elevated. I mean, there is different level of troponin that we call elevated troponin. But the non-ST elevation definition has changed recently. Was that right?
Yes, sir.
The cutoff, that's the part. And of course, there are other causes of troponin elevation. But it's an interesting case. A businessman, why is he drinking methyl alcohol when he's a rich man? He must have bought very cheap alcohol. It's very it's alarming for us, for me, because it's interesting. I left Bangladesh, and there is a taboo against alcohol, and it has become fashionable. I have gone to Dhaka club, and senior physicians, they were drinking alcohol, and they were surprised that I live in America, I don't drink alcohol. There should be some social shaming on this issue. First of all, Islam prohibits alcohol. It's not because you have to go to heaven or hell. It is because it is bad for us. And if you look at the new studies in Lancet, alcohol in any level is terrible. And I think we should campaign against this thing. I mean, it is becoming more and more fashionable in Bangladesh, and there are I go to people's house, they're very surprised that I live in America, I don't drink alcohol. And that's terrible.
Sir,
Sir, I want to
I like
say
to
something about the patient. Sir, can I say something about the patient?
Before that, Kaniz, I like to
Yes,
say
sir.
about the methanol. Methanol, ethanol is mixed with alcohol. It's almost similar to Johnny Walker, sir. So what the criminals do, they bottle these things and they have a cap machine and they recap it and relabel it with a Johnny Walker and sell it in the higher hotel and other wine shops. So from there they buy with high price, not cheap, sir. So these are the criminal things going on.
Kaniz, can I ask you a quick question?
Yes,
when,
sir.
When your junior doctors saw this patient, did they consider methyl alcohol poisoning?
Yes, sir.
I mean, this is very interesting. Man, I left medicine behind a long time ago, but this visual issue, right?
Yes, sir.
That was the clue,
And
right?
sir, I want to say something more about the patient history. He was a non-Muslim living in old Dhaka, and he has business with gold jewelries. He has a tattoo all over his arm, forearm. So I think he's regular
Drink.
drink.
Well, if you look in Bengal, you see, Bengal, it doesn't matter whether it is a Muslim or Hindu. Alcohol was not very common thing in Bengal. I mean, I grew up in Bengal, which it didn't matter whether you came from a Muslim family, Hindu or Christian family, whether there was religious, socially it was a bad thing in Bengal. But I think that has changed. That's unfortunate. But that's a problem all over the world now.
Sir,
So,
can you back to Wadud's question again, sir? Wadud's question.
Yes. No,
Sir, actually, sir.
Yeah, go ahead.
Sir, actually, Wadud's question was working diagnosis, that is injury versus non-STMI. Yes, because as the patient is unconscious, we cannot give often the history, that is the history suggestive of ischemia, but there is rising and fall of the troponin.
Yes. We have added a new diagnosis, elevated troponin. Before, we did not have that diagnosis. We used to call any elevation of troponin as non-ST elevation microinfarction. But in our diagnosis code, we have a new diagnosis that we do not commit. If we do not think that it has left a cutoff level, we do not call that non-ST elevation microinfarction, because once you put the diagnosis, it stays with you for a long time.
Right, sir.
Thank you.
Kaniz, next case, please.
Mrs. X, she was a 67-year-old diabetic, hypertensive and asthmatic lady. She had complained of respiratory distress for 1 day without any chest pain. As she was having asthma, so her family member thought that this respiratory distress is due to acute exacerbation of bronchial asthma, and they tried to manage her at home. Due to COVID, they were afraid to bring her to hospital. But after one suddenly lost her consciousness and was brought to emergency, and through emergency she was directly admitted to our ICU. Admission, her pulse rate was 80 per minute, blood pressure was 180 over 100 millimeter of mercury, GCS was 8. She was immediately intubated and put on mechanical ventilator. This was her ECG done on admission. Sorry for the technical fault in lead 1. Yeah, so sorry for this technique. We can see here that as lead 1 cannot be seen here, in AVL there is Q wave and ST elevation in V2, V3, V4 with asymmetrical T wave inversion. Her troponin I was very high, that is 4.7 nanogram per ml. Bedside echocardiography done by our cardiologist reported that it was anterior ischemia with concentric left ventricular hypertrophy. Ejection fraction was 52%. As patient was unconscious, so we did brain imaging, which showed massive left-sided intercerebral hemorrhage with ventricular extension. Sir, I had almost similar case next. So should I move on or discuss on this ECG?
Now we should discuss this case, I think.
Atahar bhai, what will be your differential diagnosis for this ECG?
By ECG, it is the anterior myocardial infarction, definitely.
Is it Whelan syndrome?
ECG diagnosis.
It could be
Whelan
Whelan
syndrome?
syndrome like.
Yes,
But
this is the suggestive of the Wallen syndrome, but
could
there
it
is a elevation.
be with intracranial hemorrhage?
This is the reason I think the Kaniz has presented this case, as because this patient has got the intracranial hemorrhage with this such type of ECG. So, problem, sir.
Kaniz, what was the
Sir,
troponin?
4.7 nanogram per ml, cutoff value was 0.06.
And there was wall
Yes.
motion abnormality. To call it MI as well. But the point is that day, Rafiq sir was reminding us that we should always remember in case of intracranial hemorrhage that the patient may have stress cardiomyopathy. And in that case, we will be having some ECG changes and there will be raised troponin. But if we look at the echo very well, we may find that there is ballooning, apical ballooning or regional ballooning.
But before that, I have got one question to Kaniz. Kaniz, actually,
Yes, sir. Yes, sir.
you saw the ECG first before scanning.
Yes, sir.
After this ECG, whether the patient received any, that is the loading dose of the antiplatelet or like.
No, sir. No, sir. Sir, in our ICU, we always follow that protocol that if the patient has altered level of consciousness, we never give any type of antiplatelet or anticoagulant without doing brain imaging. It is a protocol. It is a protocol in our ICU.
Actually, that is the protocol in almost all the ICU, and that should be followed as well in CCU.
Sir, I have a question here.
Yeah.
Before that,
Patient had.
Before that, I like to make a comment here. If you look at the AVL, there is a P wave is inverted. How can you correlate? If there is a limb-lead inversion, reversal?
Asad, can I say
Sir?
something? My rule of thumb is that if one of the limb leads showed straight line,
Yes, sir.
no,
I've seen, sir.
you should not consider that ECG limb part.
No, sir. I'm just as there is one is missing here.
Maybe, but
AVL, there is
but
a inversion.
AVR is negative. That is
Yes, sir.
so
Yes, sir.
I think this is consistent with the normal findings. As the P in AVR is negative, what should be actually?
No, whenever you get a straight line, there is a very likelihood there is a upper limb, lower limb lead displacement, transposition. That's the problem. And we should have a second ECG properly placed and then consider whether we should be declaring anything. I would not consider anything on the limb lead part. I would only consider the chest lead part. Rafiq sir.
Yes, I think I agree with you, because what I want to re-emphasize what Wadud is saying is that once we have lost one of the limbs, the AVL, they become, it'll be changed because the configuration has changed. So we should just look at the other leads. 2, 3 AVF is upright, so we can say, well, most likely this is sinus rhythm. But if we want to determine whether it's sinus or not, then we have to have the other lead placed and then repeat the ECG. Go ahead.
Sir, should I ask my question?
Yes.
So patient had complaints of respiratory distress for 1 day, though she didn't complain of any type of chest pain. And later she had lost her consciousness. So what should we think that what was the primary effect? MI followed by intracerebral hemorrhage?
Hello, sir.
the timing. The question is the shortness of breath, and I don't know if there was any chest discomfort because patient is unconscious, patient cannot tell anything. If the shortness of breath was there for a day, we have to assume that the cardiac event came first. And who knows, maybe the discomfort itself increased the blood pressure more than what we are looking at now and resulted in the CVA. So sequentially, I think probably the coronary event came first, followed by the CVA.
Sir, alternative explanation can it be, sir? That is the stroke was the first, followed.
The question is that is it possible that stroke came first, followed by cardiomyopathy? Yes, but stress cardiomyopathy should not show this ischemic change, unlikely, and the troponin elevation. Those are kind of, because this is a remarkable ST elevation. If you look at stroke itself, you get much deeper, almost symmetrical T inversion without the ST elevation, but this is clearly ST elevation with an evolving MI and consistent with the clinical finding.
But sir, in this COVID era, in who have Takotsubo cardiomyopathy, looking with COVID infection, they have typical ST elevation like simulating MI. Only after looking at the echo and doing the angiogram, we find that they actually the patient do not have coronary atherosclerotic disease, and later re-evaluation find out that this is actually a case of Takotsubo. That can happen, sir. Actually,
yeah, sure. But the question is clot which dissolved. Yeah, I mean it's a possibility, definitely, no question about it. But that in all those, in the differential that CVA followed this Takotsubo, why will the patient then shortness of breath from a stroke, right? And I'm sure the family member mentioned, right, Kaniz, that patient patient gets shortness of breath. But this is a tough case. Yes, what did you do about this patient?
Sir, patient ultimately developed brain death. Neurosurgeons opted for conservative management, and patient had brain death, and we declared her later.
Actually, this case actually emphasizes that sometimes both intracranial hemorrhage and cardiac problem come together. And whenever this happens, we have to consider the brain hemorrhage thing first and foremost. We cannot give nothing. And we also should not be using nitrate as well very much, because nitrate can increase the intracranial pressure, and that can lead to more problem. And the patient may have prolapse of the brain because of raised cranial pressure and may die as well. And this patient had actually shifted a midline shift, isn't it?
Yes, sir. Sir, as use nitrate, but if not in this case, but in other cases when there severe hypertension, like blood pressure is more than 220 or diastolic is more than 120, we have to use intravenous antihypertensive. And we have two options in our ICU, that is either nitrate or labetalol. But in case of patient with brain pathology, we usually prefer nitrate, because in case of if we give labetalol, there may be bradycardia, and we can, in that, if the patient develop raised ICP, that will be difficult for us to think what is the cause of the bradycardia, whether it is due to labetalol or raised ICP. So which should be the first choice, labetalol or nitrate in case of cardiac plus CNS event?
Actually, the best choice is a calcium channel blocker, nicardipine. And there are some new medicine that has come up. Those are also calcium channel blocker. And labetalol actually produces...
Nicardipine is available in IV route, sir, in our country?
I would prefer both labetalol and a little bit of nitrate combination. Labetalol actually do not produce that much of bradycardia, except in very high dose. I'm telling that from wide use of this experience after using this. But use that problem. Nicardipine, very good choice. I do wish some of our company, pharmaceutical company, should bring this wonderful medicine, because nicardipine do not increases intracranial pressure, do not increase coronary ischemia. It's a very balanced dilator, and it reduces pressure without increasing the heart rate. So it's a wonderful drug in case of acute hypertensive emergency situations.
Atahar bhai, can I add something, please?
Sure, Kaniz bhai, welcome.
Actually, nitrate usually predominantly dilates the extracranial blood vessels, not the intracranial blood vessels. And there is a possibility of shunting of blood towards the extracranial arteries, and there might be secondary cerebral ischemia. So it is the use of nitrate is not necessarily lead to the raised intracranial pressure, but there may be shunting of blood, and ischemia after intracranial hemorrhage is one of the most important cause of morbidity and mortality after intracranial bleed. And there, Dr. Professor Wadud has rightly pointed out that nicardipine is the drug which can reduce the vasospasm and reduce the subsequent cerebral ischemia. So, with use of nitrate, there is a chance of aggravated cerebral ischemia as well. And we should also that nitrate is not an antihypertensive drug. By any classification, nitrate, though we use it, but it is not included in any classification of antihypertensive medication.
Kaniz, one question is why craniectomy to reduce the pressure and VP shunting was done in this case?
So it was not done.
Why was not it done?
Because, sir, when the neurosurgeon visited the patient, I have shown that on admission her GCS was around 8, but when the neurosurgeon visited the patient, her GCS fell down to 5 or 6, I think. And as the prognosis was not good, so neurosurgeon opted for conservative management.
Actually, whenever the GCS falls below 8, 7 or below, in that case, even with surgical intervention, the outcome is, in our country at least, very, very bad. So, doing an intervention, creating a huge bill and taking the dead body out of the ICU, all these three things create a lot of problem for the doctor and the family as well. So, when the GCS is low, the surgeons very much unwilling to do it. Second is, she had an MI as well. That creates any patient with MI, acute MI, ST elevated and troponin is raised, regional valvular inflammatory present. In that case, any surgical option can lead to massive cardiac problem issue as well, and the outcome is very likely low. So I would actually opted for the same thing as the neurosurgeon has done.
So, Kaniz Fatema, actually,
Yes, sir.
What is the conclusion finally? That is for the severe blood.
Sir, a brief discussion after the next case, similar type of case. After that, I have a brief discussion.
That is the management of the hypertension in such cases. That is the nitrate versus levodopa versus nicardipine. Actually, what will be the final?
First of all, in case of intracerebral hemorrhage, we should not lower the blood pressure very aggressively. We have to keep the mean arterial pressure more than 90 or 100. It should be our target. And if we have to lower the blood pressure, then as sirs have said that the nicardipine should be the first choice, as it is not available till now. So we can go for labetalol. That's the thing, sir.
Thank you. Next case.
Sir.
Can I do you have sodium nitroprusside in Bangladesh?
Do you use Kaniz Fatema?
Sir, we do not have it in our ICU. I don't know about, sir.
The thing about drugs in this situation is you want to use a drug that has very short half-life and that washes up quickly. Sodium nitroprusside has half-life of 2 minutes. So the sodium nitroprusside is It's only intravenous, there is no oral preparation. This kind of situation, you can titrate. Nicardipine half-life is 48 minutes. So if the blood pressure drops, then you have to wait for a long time. So that's one drug. I mean, it's an old drug. Even in this country, we use it less and less, but it is a wonderful drug in this kind of situation. Thank you.
Thank you, sir. Now the next patient, he was a male patient, 55-year-old, diagnosed case of bronchial asthma, hypertension, diabetes mellitus, and end-stage renal disease. He was getting regular maintenance hemodialysis thrice weekly. He had complained of altered level of consciousness for last 12 hours. As per his wife, he had regular hemodialysis on the day before his admission in ICU. After going back home, he became sort of drowsy, though his wife said that she could feed him by mouth. He was taking food, eating, but his eyes were closed. And then she thought that he was sleeping. On the next morning, he was not getting up, so she brought him to the hospital. And from emergency room, he was directly admitted in the ICU. On admission, he was grade 4 unconscious. Pulse was 100 per minute, blood pressure 160 over 90 millimeter mercury. Patient was dyspneic, saturation was 85% with supplemental oxygen 10 liter per minute through face mask. So we immediately intubated the patient and put him on mechanical ventilator. Plantar were bilaterally extensor. ABG, which we did on admission, showed patient had severe hypoxemia with respiratory alkalosis and metabolic acidosis. He had hyperkalemia with raised urea and creatinine level. This was his admission ECG, which showed sinus tachycardia with T inversion in lead 1 and AVL, and biphasic P wave in V1. Bedside echocardiography, which was done on the same day, showed concentric left ventricular hypertrophy, enlarged LA, enlarged right atrium and right ventricle, and LV systolic function was good, that is 46%. As the patient was unconscious, so we did brain imaging, which showed brainstem hemorrhage with ventricular extension. On next morning, there we found some changes on the cardiac monitor. So we did an 12-lead ECG, which showed that there was ST depression in lead 1, 2, 3, AVF, and V6. Their biphasic P wave was present in V1 and V2. Sir, the case ends here, and next I have some discussions. Before going to discussion, should we discuss the ECG of this patient?
Yes, Kaniz, I think this is, we should discuss the ECG first.
This was his first ECG.
Take you1.
What is the pressure level, first day and second day?
So his blood pressure was maintained all over. On admission, it was 160/90. And later it was around 140/90, 150/80, around that.
Achha, Kaniz, before Rofik sir, anyone panelist can comment on the ECG? We'll hear the comment from Rofik sir after. For that, anyone panelist? Next ECG. Khalid bhai, this ECG.
This is it seems there is a horizontal ST depression, and the patient had tachycardia also. One possibility is maybe tachy-induced.
Now, what is the rhythm? Sinus tachy or anything else? What is the diagnosis?
This is sinus tachy actually.
Sinus tachy.
Yeah.
The clear P waves are seen in V1, V2,
and there
as well as in lead 1.
There is some hyperkalemia, kalemic type of T wave changes, which was not present in the previous ECG actually. So this is a new change actually, and there is widespread ST depression. So maybe there is some electrolyte imbalance, and the patient might have developed some non-ST elevation MI actually, maybe.
As the rate is nearly 150,
should we consider as
ST
SVT, sir?
depression,
Atahar, sir?
can it be
The P waves are inverted.
fatal?
P
Sorry?
waves are inverted, which
Sir,
is not
sir,
there. Yeah, the P waves are
Yes,
inverted in
Sudeep.
the V1 and V2. In the sinus rhythm, if you have noticed, in sinus rhythm, it is upright. And probably he has developed some sort of atrial tachycardia. And due to tachycardia, there is the associated ST depression, not due to the ischemia.
But the
So
P waves are
atrial
P
tachycardia-
wave
upright
in the
is-
first ECG, it was also biphasic.
Yeah,
Like
but
this
now
one?
you can see clearly inverted in V2. If you look at the second
Yeah.
ECG, the P waves are clearly inverted. And if
Sudeep,
you
as the rate is nearly 150 and the ST depression, is there any possibility of atrial flutter?
The
what,
thing, actually, the biphasic P wave in V1, which is clearly seen here, excludes that it could be anything other than sinus origin tachycardia. Rafiq sir, what do you suggest, sir? Sir is out.
No, sir,
So it's tachycardia, no question. Its rate is a little bit over 150, but in V1 it's biphasic. It is true that V2 is biphasic, which was not there before, but is it possible that the lead position is a little different? That's a possibility. And the 2-3 AVF is upright, and 1 is upright. AVL, I cannot make a comment. So I consider this as sinus tachycardia. But the thing is that there is ST depression in V6 and 2-3 AVF. If you look at the baseline ECG, there was 0.5 millimeter ST depression in V6. This patient has hypertension. So I mean, yes, when there is horizontal ST depression, that can be subendocardial ischemia, but it is possible that LVH-related subendocardial ischemia has been exacerbated by the tachycardia, as Jamil was pointing out.
Sudeep, do you want to add any comment?
the differential could be still the atrial tachycardia. And if you look, because why the sinus tachycardia rate? I mean, initially also in the first ECG also there was sinus tachycardia, but here the rate is clearly increased. Still possible that the sinus tachycardia rate has increased, but looking at the morphology of the P in the V2 is clearly pretty much not only biphasic, is the negative component very much. So I still think the possibility of atrial tachycardia.
Thank you, Sudeep, for your nice differential diagnosis. So, sir, what we should do, sir, in this case, sir, for the practical management purpose, what should we do next, sir? Whether we is there make any difference for the management purpose, sir, the atrial flutter or the atrial tachycardia? That ECG does not give any definite clinical differentiation, sir.
Well, as Shujib mentioned, I mean, there are only two considerations. One, is it an atrial tachycardia, or is it sinus tachycardia? One or the other.
Sir.
Question would be, what was the rate and how did it go up? I think it's very important to look at the pattern of the change. I mean, if it has gradually gone up from the before and the patient is getting sicker and sicker, and it's more likely point towards sinus tachycardia. If it suddenly increased to this rate, let's say the heart rate before was 90 and suddenly goes to 150, 160, then definitely it's not sinus tachycardia, it's something else. And so the management wise, I mean, I will definitely start with beta blocker first, if the blood pressure tolerates, to slow the rate down. That will be my first line of treatment.
Should I proceed?
Yes.
Yeah.
Thank you, sir. Now I like to say a few words about acute stroke-induced cardiac injury, which is of utmost clinical importance. Some ECG changes and raised cardiac biomarkers are common in case of ischemic stroke and subarachnoid hemorrhage, but it is less frequent in case of intracerebral hemorrhage. Cardiac injury, any type of cardiac injury following acute pathology of the central nervous system without any evidence of primary cardiac disease may result in structural and non-functional disturbances, which is known as cerebrocardiac syndrome. And this is mainly caused by the neurogenic stunt myocardium. Neurogenic stunt myocardium is the sudden onset of myocardial dysfunction, which brain disease from autonomic disturbances. Though the pathophysiology is not clearly defined, it is thought that after the acute brain insult, there is autonomic dysfunction, hyperactivity of the sympathetic system, and there is raised catecholamine level in the blood. It is seen that the catecholamine level raised up to 20 times higher than the normal level, and it causes hypermetabolism and hyperdynamic circulation, which increases the myocardial oxygen demand and causes coronary vasospasm. All this cause cardiac injury. There is also some sort of inflammation-mediated myocardial injury, which is caused by the release of some cytokine tumor necrosis factor from the brain, which causes the systemic inflammatory response syndrome, damages most of the organ, including the heart. And the typical clinical manifestation are not always present because the typical symptom may be concealed by the neurological deficit, especially if patient has some cognitive or language impairment. There may be features of hemodynamic instability or features of autonomic dysfunction like tachycardia, hypertension, sweating, tremor, etc. There may be some ECG changes like ST deviation, QT prolongation, T-wave abnormalities, left ventricular hypertrophy. But unlike the acute coronary syndrome, these ECG changes are usually of short duration. They usually persist for 5 to 14 days. CKMB may be raised, but there are other causes of raised CKMB other than the cardiac cause. Troponin, cardiac troponin, INT, these are also raised, but the rise is usually modest, not as high as seen in acute coronary syndrome. And echocardiography may show left ventricular systolic dysfunction or sometimes regional wall motion abnormalities. And these features are also of short duration and transient. The management, there is no clear-cut treatment available for cerebrocardiac syndrome. Close observation is needed for the first 1 week. Patient should be evaluated sequentially with doing daily ECG, cardiac biomarker, and echocardiography. Prognosis is usually bad in case of cerebrocardiac syndrome. The mortality is 4 times higher in patient with cerebrocardiac syndrome than patient who do not have any type of cerebrocardiac syndrome. And we can predict the prognosis by seeing the level of the troponin I. If the troponin I is higher, though it is not acute coronary syndrome, but the prognosis is worse. This is a few words about the cerebrocardiac syndrome. Now my next case, a 75-year-old male. He was hypertensive on regular bisoprolol and furosemide. He presented in our ICU with restlessness and weakness in the right side of the body and slurred speech since the morning of admission. On admission, patient was drowsy but responded to vocal command. Pulse was 96, blood pressure 110/70, and saturation was 98% with 2 liters of oxygen through nasal cannula. This was his admission ECG. Patient had hip surgery done on the same hospital about a year back, and at that time his ECG was available. At that time that ECG was sinus rhythm, but in this time we can see that patient had atrial flutter. Patient's blood pressure was 110/80 on admission. Art gas, CBC, renal function, liver function, all were normal. Echo, which was done a year ago, showed mild anteroseptal hypokinesia and ejection fraction was 54%. As patient had complaint of left-sided weakness, so we did MRI of brain, which showed acute infarct in right temporoparietal and basal ganglia region with cortical atrophy and ventriculomegaly. After admission on the next day, echocardiography was done, which showed concentric left ventricular hypertrophy, and this time ejection fraction was 59%. We did thyroid function test, which was normal. This was his ECG on third day of admission. On day 4, cardiac monitor showed his heart rate was varying from 100 to 120, 140, 160. So the duty doctor took this ECG and he was thinking of atrial fibrillation. So he started injection amiodarone. After giving the loading dose of 150 milligram, this ECG was taken. Then he started the next dose of injection amiodarone, that is 360 milligram. But just after starting that dose, patient developed hypotension. So injection amiodarone was stopped, and we have to start injection noradrenaline. After giving noradrenaline for a few hours, his blood pressure was again normal, that is 110/70 millimeter of mercury. This was his ECG on day 6. We took consultation from cardiologist, as patient was, his blood pressure was normal, his conscious level was improved. So we ultimately shifted the patient from ICU to ward, general ward. So that is the case. Sir, I have question regarding this ECG.
Yes, you can ask question.
Sir, after giving injection amiodarone, 150 milligram, the first loading dose over half an hour, patient had this ECG. Sir, here, can we call it P wave, or still this is the flatter wave? There is 2 positive waves side by side. What should we call this?
Jamil.
Sir,
unmute,
sir,
Jamil.
You have,
Yes,
you have to unmute. Jamil sir, you have to unmute.
It looks like QM preceding every QRS complex, and it's bifid QM. But the duration seems to be normal, so normal QM may be bifid.
Okay.
There is another striking feature, that is acute prolongation of the QT interval.
Right, exactly.
Yes.
Induced by the amiodarone injection.
Amiodarone.
Possibly the patient hypotension, possibly the patient had developed some form of polymorphic ventricular tachycardia or something, torsedis de pointis, which might have led to the hemodynamic deterioration. That, otherwise, amiodarone is relatively a very safe drug from a hemodynamic point of view until it induces some form of polymorphic VT.
Either VT or profound bradycardia might lead to hypertension also.
So, Kaniz.
Yes, sir.
Sir, after 150 milligram of amiodarone, this was the ECG, na?
Yes, sir.
Why there was second dose?
Sir, duty doctor, this was given by the duty doctor. He was a little bit confused. Usually, we, if the ECG converted to sinus, we do not continue the amiodarone. But he continued the injection amiodarone, and just 20 to 25 minutes after starting the second 360 milligram dose, patient developed hypotension. The 360 milligram dose, we usually give it over 6 hours. But after giving only for 20 minutes, patient developed hypotension, so it was stopped.
So, Khalid bhai, do you consider this prolonged QT is due to the amiodarone?
It is the most important factor is amiodarone, because it has, the previous ECG did not show a significant QT prolongation, but there might be other factors as well, like the electrolyte imbalance or myocardial ischemia or some other offending drugs which might have contributed. But it's acutely developed after amiodarone bolus injection. So this is quite obvious at this moment. Maybe.
Is there Sujib Bhandari?
Can the QT prolongation due to that insult in the brain itself, like in the previous slides he has mentioned that
Maybe.
QT prolongation?
Yes, it can. Yeah.
It can be.
And what was the magnesium level of the patient? Was it normal?
Yes, sir. It was normal.
Sujib, do you comment on the P wave again? That is, the P wave is V1 is positive, not biphasic, and there are some changes in the P wave. Do you have any comment?
P wave looks normal. The P wave duration is also not that broad. Considering the flutter, if the right atrium or the left atrium is enlarged, it doesn't show the features of the either atrial enlargement. I think the P wave is normal, except in AVL. If you see in the AVL, the first bit of the AVL, there is a slight peaked P wave, which could be, it's in the AVF also. So it's not an artifact. AVF you can see if you compare. Maybe there's some that could be an atrial ectopic. Maybe, I don't know. But the next two P waves looks normal.
Actually, the patient is Kaniz. Is the patient too obese?
Not so that much. I think he was a male patient. Height was around 5'10", and weight was around 70 kg. Not that much.
Not that much. He has a left atrial enlargement, obviously. Could that be a contributing factor for the appearance of the atrial flutter? Sir?
Okay. Now, can we go back to the ECG before during atrial fibrillation, please?
So this was his first ECG on admission.
Next one, please.
This was on day 3. This was day 4.
Okay.
After doing this ECG, duty doctor gave him injection amiodarone.
Sure. So a few things. So this patient clearly had a stroke, right?
Right, sir.
Was the patient started on anticoagulation?
Sir, I actually consulted this case with Professor Wadud sir and Professor Atahar sir, and we have started anticoagulant at our ICU.
Sure. So the issue is the rate is well controlled in this case for a patient like this. So there is no urgency to convert him. My concern is that, first of all, we're discussing what caused the hypertension. Hypertension was done by the amio. That can happen. But the question would be that, is there any need to give amiodarone in this patient? I wouldn't do it because the rate is well controlled. I'll rate control this patient and then let this patient get over the stroke issue and then decide what to do with this atrial fibrillation. The other problem with conversion, the one thing that we worry most, I would rather keep this patient in fibrillation because his chance of stroke will be less than if he converts. Because if he's not been adequately anticoagulated long enough and if there is a blood clot, it converts to sinus and strokes again. So that's the other issue. So we have to go into this issue. Second issue is that if we give amiodarone, is there any need for bolus at all? When will we give bolus? We give bolus when somebody is very sick, somebody is in VT, and we have to make the medicine work very fast. So you have to teach your doctors in the floor that, look, what are the conditions that we are going to give IV amiodarone bolus? And that will be this is not the patient that I'm going to give bolus. If I have to give amiodarone in this patient, I'll probably start PO, no, not IV. If for any reason I have to start IV on a patient who is hemodynamically stable with atrial fibrillation, which is very rare for us, I'll give the 150 milligram over half an hour, 1 hour. You don't have to give it over 10 minutes. So that was a pretty big dose of amiodarone to give in a patient. And also, we also have to understand, I think in a patient with stroke, we do not know what the autonomic system is doing. We probably don't have much experience. So I probably have avoided.
I have a comment.
Sir, we give it on over half an hour.
Yeah.
Rovik bhai, can you hear me? Rovik bhai, can you hear me?
Yes, Hafiz bhai, we can.
Yes.
So I have a comment. Maybe you sounded very humble in terms of amiodarone. In this case, I want to be a little more aggressive. because we have to have a clear idea that why we give amiodarone, as you said, for the dream of cardioversion, because the amiodarone cardioversion to sinus rhythm is at best 30 to 40%. And then in the rate control situation, we give amiodarone also, an IV. In this case, there was no need to give amiodarone. And particularly IV amiodarone in a stroke patient, with there is a hemodynamic problem, the stroke may get worse. So I don't think that it is a situation where we can say we may give amiodarone. I think amiodarone IV is contraindicated in a situation where the rate is controlled. I don't know what we are going to achieve by giving amiodarone. So I don't understand that. So that's why I'm a little aggressive on this, that we should be pretty clear in mind. And you pointed out, Rafiq Bhai, that if you give slowly and whatever. But rate control, it does work. But here rate was already controlled.
Yeah.
Sir, can I add something?
Yes.
In our country, we have to deal with two types of patient. One is the rheumatic valvular heart disease patient who have atrial fibrillation, and very often young patient come with stroke. In those cases, with fast ventricular rate, we prefer control ventricular rate with the actually digoxin. In case of ischemic origin or otherwise atrial fibrillation, non-valvular origin, in those cases, for rate control, we prefer amiodarone. And I agree. Sometimes, as Sir was saying, in this cases, actually, you want to convert it to sinus oral amiodarone so that gradually the amiodarone build up, we get the chance of anticoagulation, and we can evaluate the patient whether the patient have any thrombus or anything, and then can in time the patient may convert to sinus rhythm. And as you were saying, it's only around 30%, 35%.
Yeah. Well, Hafiz has been generous about conversion rate. Conversion rate with intravenous amiodarone or any drug is 10%. Also, we have to remember, new onset atrial flutter fibrillation, 50% will convert without any medicine. Hafiz has given me more courage to be a little bit more aggressive about amiodarone. We do not use amiodarone for rate control at all, unless I am very stuck. And the situation will be, a patient comes with a blood pressure of 90, atrial fibrillation, rapid ventricular response. I give digoxin and it doesn't go down. I cannot give calcium channel blocker. I cannot give beta blocker. I will very cautiously use amiodarone intravenous without bolus. So it is not a drug that we take lightly anymore. So we keep that in the arsenal in the back. For rate control, we are not using it at all.
So the problem is much more rate controlling drug. The beta blocker, no IV beta blocker available except labetalol, which is not a rate controlling drug. The second is we have digoxin and we have amiodarone. That's it.
So yes. let me say something about this, Rafiq Bhai, because in cardiology, one thing we are very helpless in a patient with AFib and fast ventricular rate when the blood pressure is low, cardiomyopathy, and in those situations, we have only two drugs that we can depend on. One is DIG, one is amio. The problem with the DIG is that it takes 6 months, even with the IV, to get the rate control. You may be lucky, you can give and regardless of the renal failure, I'm telling is for the junior physicians. For loading dose, digoxin is okay in renal failure. But after the loading dose for the maintenance, you need to be careful about digoxin. And particularly, I would avoid in dialysis patients. You can give one dose and forget about it and do not do maintain. But for the amio is actually a very good drug in a situation like post-cabbage and then in the trauma situation where there is no other way we can use anything else. And IV amiodarone, we give like a 150 and then repeat the bolus 150 if needed. And our experience is that it's a very good rate control drug in those situations. And I agree with Rafiq Bhai that I don't use it rampant for everybody with amiodarone, where we can use other drugs.
Well, Hafiz, what you said is that you use it in special circumstances. It is not a drug of first choice or reflex use of. Other point is digoxin. Wadud, I'm glad that Wadud mentioned digoxin. Digoxin actually is an underused drug. It is a very good rate control medicine because it does not lower blood pressure. It doesn't do anything else. And even in rare failure patient, we can use it in a controlled fashion. And there was some publicity that digoxin is a terrible drug, but there is a recent review, and actually there is a placebo-controlled study which showed that digoxin is a good drug for rate control in certain group of patients. But these are be customized, as you mentioned. But of course, I take your point that when we don't have any other medicine, what shall we use? Yes, we have to use it. But we also have to remember that if we find the alternate, we should look for the alternate. It should not be a blanket thing that let's use amiodarone all the time.
Rafiq, sir, may I ask a question to you, please?
Yes.
What about the other commonly used agent for rhythm control, like sotalol, propafenone, and flecainide for conversion of amiodarone to sinus rhythm?
For this patient or in general?
In general, actually.
In general, the conversion rate with antiarrhythmic drug in established atrial fibrillation is 10 to 20% by the medicine itself, unless it is paroxysmal atrial fibrillation. And the other thing, if you look at all the studies, that patient comes to hospital, and if you randomize them no antiarrhythmic versus antiarrhythmic, you'll find that less than 7-day duration of atrial fibrillation, majority will convert by themselves. And when we give them medicine, we take credit for it. But I don't think there is any credit to us. It's just a natural conversion of the medicine. But this patient is a difficult patient, because question would be whether we really should convert this patient or not, especially in the setting of a stroke. That we have to be careful.
Kaniz, I think, full of answers.
But Kaniz is bringing good cases. This is wonderful, because you are really bringing a different perspective of, especially this discussion about stroke and troponin. It's a very, very interesting topic, and I hope that you bring more cases like this, because that gives a dimension of cardiology and interrelation between specialties. This is wonderful.
Thank you, sir.
Wadud bhai. Kaniz?
Sir, this is my last case.
Yes, please.
Unsolved mystery. A 73-year-old male patient. He had complaint of parrectal bleeding, and he was mainly brought in the gastrology department. It was not in BIRDEM, it was an outside hospital for doing colonoscopy as outpatient basis. But after colonoscopy, patient became semi-conscious. On examination, his pulse was 48 and blood pressure was 90/50. So he was immediately transferred to our ICU. As I have mentioned that this is a case of unsolved mystery, we got the patient only for half an hour to 1 hour time. After that, patient party took discharge on respond and take the patient to another outside hospital. We searched his previous document. He did not have any previous ECG before doing the colonoscopy. His family gave no history of previous heart disease. And this was his ECG. We labeled him as complete heart block. And as I've said that this is an unsolved mystery, we do not know the fate of the patient. Sir, I have a question that the tall peak T wave, as the patient suddenly became semi-conscious, should we consider it as acute MI complicating the complete acute MI causing complete heart block?
Kaniz, before going to your question, I should discuss the ECG diagnosis first.
Okay, Yes,
And
sir.
finally, Rohit sir will answer lastly, but before that, we should take the comments from our panelist about the ECG diagnosis. Sir, from our panelist, ECG diagnosis.
Sir, can I?
Kaniz, yes, you can comment.
Actually, the patient has a background of right bundle branch block, and with probably it is a bifascicular block, and the patient has developed some complete heart block, which is in the background of bifascicular block. Maybe some maybe these patients are prone to develop, definitely, and particularly under some stressful situation or under some influence of medication. So probably this is the reason. Maybe the patient, they're always vulnerable to develop high degree AV block, the patient with bifascicular block.
High degree or complete heart block, Khalid bhai?
Complete. This is complete.
But I think there are some evidence of the sinus beat, sinus rhythm. As for example, the lead 2, beat 1, that is beat 2, and number 4, that is the number 1, 2, 3, 4. These are the sinus beat, I think. As a Rofik sir will comment lastly, Wadud bhai, complete heart block or high degree AV block?
Look at the RR interval. It's fixed. Look at the P wave. It's fixed. Look at the association. There is none. So it's complete heart block. And I don't physical block. It's complete right bundle block pattern. The point is whether colonoscopy has induced any vagal, increased vagal tone and lead to this problem or not. I'm not sure.
So in the EKG test, they actually want you to say that what is the atrial mechanism, what is the ventricular mechanism, and what is the relation between the AV. So it is a perfect example of that there is sinus rhythm and there is ventricular mechanism, which looks like narrow complex, probably junctional escape rhythm, and then there is dissociation, AV dissociation. AV dissociation, I'm telling you for this, does not mean heart block, we all know, because in ventricular tachycardia, there can be AV dissociation, in which case the ventricular mechanism is faster than the atrial, and there is AV dissociation. Just to make sure that we are on the same page in terms of what we are defining at. About the T inversion is the tall T wave that raises question, is it a hyperkalemia or is it a acute coronary syndrome? I will do the differential. I will not jump on acute MI because it is important we don't read too much into the EKG and ignore the patient's presentation.
Rofik sir?
Kaniz, what medicine did this patient get during colonoscopy?
Yes.
Sir, some sort of sedative, midazolam and plus minus else. They didn't mention the other thing.
I think two independent issues. One, midazolam use, Versed and fentanyl can cause impaired consciousness. So that's one issue. Second, this is complete heart block. No question about that. And the escape beat is right bundle morphology. And this is typical right bundle morphology. So the escape beat is a junctional escape beat. Because otherwise, if it were so the block level is in the AV node level. And so the question is, I don't think this is vagal because vagal episode cannot last for such a long time. Patient was in that colonoscopy place, and by that time came to BIRDEM, I think it was 2 hours at least. You cannot have vagal.
Sir, ICU of the same hospital, not in BIRDEM, but another hospital. But before sending the patient from colonoscopy room to ICU, in the colonoscopy room, they gave patient 5 or 6 ampulle of injection. And after that, they sent the patient to ICU.
But this ECG is clearly complete block with underlying right bundle branch block. And So is it possible that it can with acute ischemia? If it happened with acute ischemia, you have to involve the right coronary artery. And you should have seen ST elevation in lead 2-3 AVF. I think this is just pure conduction system disease. It's probably a coincidence this happened at the same time. I will not let this patient go home, and I will not take this patient lightly. How old is the patient?
Sir, as I've mentioned, the patient was in our ICU only for 30 minutes to 50 minutes, and later they took discharge on risk bond or discharge against medical advice and went to another hospital. We lost contact with that patient.
What is the age of the patient? Sir asked for age.
73.
Yeah.
Sir, 73.
So, I mean, this is the right age for somebody to develop heart block. It can be just that happened at the same time. And the other, did they do an ECG
No,
before
sir.
the colonoscopy?
We searched all
So
the
it is
paper.
also, you have to understand something, that sometimes we have patients in heart block who never came to hospital, never had any symptom. And maybe it happened that they got sedation, patient became comatose, and then that's when they found out maybe this is old. Who knows?
Yes, sir.
Did the patient go hypoxic? Become hypoxic or no?
Yeah, patient was a little bit, not that much. After giving him supplemental oxygen, 6 liter per minute, saturation was 98. But he was respiratory acidosis, type 2 failure.
Sir,
Yeah, so hypoxia, as we are seeing in the COVID time, is a big trigger also. But another comment is that atropine, if we are giving, how much atropine you need to give in a situation like this, or for that matter any situation? 5-6 ampoules, meaning 5-6 milligram?
No,
No,
one
no,
ampoule
one
has
ampoule contains
0.6
0.6
milligram.
0.6 milligram.
0.6
Also, 3
in one ampoule.
milligram given.
3 milligram is required for total parasympathetic blockade. So there is no need to give more than 3 milligram of atropine. And in our country, the gastroenterologists don't keep a standby anesthetic during the procedures. They administer these, the fentanyl, the midazolam and propofol by themselves. And whenever they are in trouble, they tend to call an anesthetist or call an intensivist. So this is the usual
Let me
practice
tell you
of
what is the
gastroenterology in
practice
this
here,
country.
because we use midazolam and fentanyl on our own, and that is called the moderate sedation. Propofol is labeled as deep sedation, and we do not administer that. And you know that propofol administration by someone for, what is his name, the rock star?
Michael Jackson.
Michael Jackson. So you got into trouble with the propofol injection at home, because propofol is a brilliant drug in terms of switch on, switch off, but it can have severe consequences also, which unfortunately Michael Jackson had.
Well, I think Khaled Moshin, the midazolam and fentanyl are given by non-anesthesiologists in the United States also. However, we have a training program. We call this conscious sedation training, and I have to take this exam every 2 years. If I do not pass that exam, I cannot give that. And in this, I think this is something that you need to consider in Bangladesh. What is happening? What happens is that we have set up questions. There is a curriculum, and you read it. It's an open book exam. I take it every 2 years in conscious sedation, and then you know exactly what to do in this: how much to give, how frequently to give, what are the protocols. It's a very clearly set up protocol. I think that it is important to set it up so that it will keep people out of trouble when they're giving sedation.
This patient was not, clinically, this patient was not a mind. I think this patient probably has some hypoxia or theory, but I usually, as Rafiq said, in the post-cath or all that, one time short-lived. If it is a second time, I tell the fellows, rookies, forget about vagal. Think about groin complications, retroperitoneal, this, that. Because we have to, these are the things that we should not compromise, because this is patient safety issues.
Thank you, sir.
Thank you.
That's all from my side. And I'm grateful again to the ECG study group for giving me the opportunity to speak among all the renowned cardiologists and learn so much from them. Thank you, sir.
Thank you. Thank you from all of us. Atahar bhai.
Yes. Thank you, Kaniz Fatema, for your excellent presentation. Sir, one more ECG from Orun Maski. Then we'll move to Orun Maski.
Arun, can you share? Today Hafiz bhai is going to show us something.
Yes, yes.
If there is time.
Then
After this ECG. And this Orun Maski's presentation is for Hafiz bhai really.
Dr. Arun Maski.
mute yourself. Arun, unmute please.
Last time we had a very beautiful lectures on STEMI and culprit lesions. So I came to this case, one lesion. So I think it's for a learning purpose.
I have a question for you even before you start.
Yes.
This Shahid Gangalal National Heart Center. This Shahid means like what
Martyr.
we know in
Martyr.
martyr. Oh wow.
Yeah. Okay.
There are many words like Bangla. Bangla words almost similar meaning in Nepal. Nepalese.
Wow.
Okay, this was a 51 years old male. He was obese, no other risk factors. In the early morning, he was attending one social function. At that time, he had a chest pain. So he went to nearby local clinic, did an ECG. And because there was only staffs doing ECG, and there was something changed in ECG, he was referred to a cardiologist for opinion. And after that period of time, he felt better. So he went back home, had his food, relaxed there, and had a chest, again his chest pain started becoming a little worse. So in the afternoon, he attended the hospital.
You doing okay?
So this is the EKG of this patient. So what we can see is sinus rhythm. There's ST elevation in 2, 3 AVF and 4, 5, V4, V5, V6. So this is his right-sided lead. Nothing much in our V3 or V4.
নানা কার্ডিয়াক টেস্ট করে তোমাকে ডাকতেছিলাম আমি তো
And this is posterior leads. The 7, 8, and 9. There's some minimal ST change, elevation in
সব এখন
posterior leads. So what is the culprit lesion in this STEMI? So this is a baseline ECG.
To me, it seems to be might be a dominant circumflex artery was occluded.
Yeah, because it's an inferior lateral leads.
Yeah, inferior and lateral.
And not much changes in one avial.
Yeah.
And it's very difficult to say which of the leads has higher ST elevation compared to 2 and 3. And if you consider the lateral leads, possibly we should consider
V4 is more.
posterior lead. Look at the V2. Tall R, upright T.
So this is a posterior leads.
Yes.
7, 8, 9. Tall R in V7, 8, and 9. Some ST elevations.
So
It will also possible the circumflex and dominant circumflex, And the other possible is a rare, but it is possible that the right is occluded from before, and the LAD
it's suppressed.
has now new lesion. that can give you this kind of scenario. But I am worried about this. What is the culprit lesion is a big question before cath and even after cath. And I'll show you my first EKG when I have a chance. But this patient is in trouble because look at this. It is an inferior STEMI. We all agree, infralateral, and there is not a dominant R and then T upright and posterior. We worry about RV, but then why it is sinus tach? This is kind of interesting to me that why is it sinus tach? That may be a big area, impending heart failure,
Yes.
and mechanical complications. All these needs to be taken into consideration.
Any inferior MR with sinus tach raises these problems, as Asan Bhai was saying.
Yeah. This history is interesting. 9 a.m. he had chest pain, subsides, does ECG, goes home, relaxes, feel discomfort, then afternoon he visits. Now let's see.
Right.
So this was the initial ECG when he first visited local clinic at 9 a.m. But you can see his lead 2, 3, and AVF, his ST elevation, and V4, V5, and V6.
But look at V2. V1, V2 should not be showing very good T waves. Any upright T waves in the background of chest pain, I always look for posterior lead involvement. I would always ask for posterior lead.
Yeah, we had done that posterior leads. There was minimal ST elevation in V1,
So
V2,
with this
and
EKG,
V3.
you went home? You went home with this?
No. Yeah, with this EKG was done in local clinic because in the 9 a.m. there was no doctors. So the person who did EKG said, go and visit your cardiologist. After some time, he felt better, so he went back home. And in the afternoon, he had chest pain. And then he visited another local hospital. And this is a ECG with sinus tachycardia. Maybe in V3, some ST elevations, V3 to V6 with sinus tachycardia. Otherwise, he was hemodynamically stable. Also, we did an angiogram. So this is a right coronary. Doesn't look anything. Looks okay. And this is his left system. Circumflex looks fine. There's a thrombotic occlusion of proximal mid-junction LAD. And if you look at this distal LAD, it's occluded here. This is another view showing thrombotic occlusions. And this is another view showing occlusion, thrombotic occlusion in proximal mid junctions. And did a primary PCI to LAD with DS. So this was a picture of this patient. He had a mild, he was a known case of renal impairment. His baseline creatinine was around 1.6, 1.7. And after doing a PCI, we just tried to see the wall motion in the cath lab, did an echo. We showed wall motion abnormality in anterior, anteroseptal, and apical area. This was a echo done post PCI in the cath lab itself. So for learning, if you find any angiogram by thrombus in angiography or imaging, that proves this is a case of acute myocardial infarctions. And immediately post PCI in the CCU, there's still ST elevation in 2, 3 AVF and persistent ST elevation in V3 to V6. next day, the ST elevation has now up to V2. So still ST elevation in V2, lead to 3 AVF, V2 to V6. And this morning, the same ECG. Otherwise, the patient is hemodynamically stable. His renal impairment has deteriorated. Now the creatinine is around 2.5, 2.6. So just for a brief academic interest, if you have ST elevation more in lead 3 compared to 2 and ST depression 1 AVL, that's RCA. And if you see 2 is more than 3 and ST elevation, that's a circumflex. And this is how you find out if in case of RV infarction, whether this is a proximal or distal RC occlusion. If there's a ST elevation, then it's a proximal. If no ST elevation, then this is a distal RC occlusions. And if you find ST depression more than 1 mm in RV4, that indicates circumflex occlusions. I'm not going to in detail of this one. So this slide is very important. If you find any patients with occlusion before the first diagnose, then there's a ST elevation in 1 and AVL. If it's occlusion occurs in LAD before main septal, then there's a ST elevation in V1, V2, and ST depression in inferior leads 2, 3 AVF, V5, and V6. So if there's occlusion between first septal and diagonal, there's no ST elevation in V1. So if there's ST elevation in V1, it indicates the septal glands are occluded. If there's a proximal occlusion, proximal to first septal and D1, there's a ST elevation in V1, V4, as mentioned earlier, and there's a reciprocal ST depression in inferior leads. If there's a distal LAD occlusion, distal to first septal and first diagonal, then V1 AVL are spared and there's no ST, reciprocal ST depressions. Sometimes we have a very long LAD which wraps around the inferior, wraps the type 4 LAD which wraps around the apical area, and if it supplies significant portion of the inferior wall and its occlusion causes the inferior ST elevation MI in inferior ST elevation in 2, 3 in AVF. So this distal LAD occlusion may be deceptive. So what we find here is we do not find any changes in 1 AVL V1, so it virtually excludes these proximal occlusions. There's ST elevation in V2, V3, lead 2, 3 and AVF, and in 4, 5 and 6. So if you look at this angiogram here, there's a distal occlusion here, and post PCI also there's a apical area showing there's a occlusion in the distal LAD. So we did not try to open that LAD because it looks like very small. So that may be one of the reasons why the persistent ST elevation is there. So the culprit lesion was LAD. There was a thrombotic occlusion distal to first diagonal. Hence the septal branch of LAD was not involved. And there was a large distal occlusion of LAD. This was supplying significant portion of inferior wall. So the culprit lesion was LAD, but the area of supply was very large and the LAD was wrapping distally. So ST elevation was there in inferior leads. And the distal vessels was not open in this patient. So persistent ST elevation in inferior leads could be the reason of why, because there was a distal occlusions. Thank you.
Thank you, Arun, for a very interesting case.
But honestly, this is not surprising because the wraparound LAD sometimes gives this ST elevation in the inferior. We call it distant ischemia, giving rather injury type. So even in the EKG question book, this division with the prox LAD versus mid LAD or the prox RCA versus mid RCA, all these have to be taken out because these are all good to know from the EKG, but you can't really bet on this with the territory not always be consistently right. So I am not that emotional about just EKG dictating everything. We see surprises, and that is not sort of rare. That's very common. But one comment on this, that in a situation when you don't restore the distal apical flow, I usually tweak with the wire and with the balloon daughtering, and then see there is a significant microvasculature problem or not, which clearly in this case has. And then I try to give medications that help microvasculature. If the EDP is high, still having chest pain, balloon pump. If the EDP is not high, and then we can give, the glycoprotein 2B3A inhibitors. And before leaving the lab, we dump like adenosine or nicardipine or verapamil, depending on what we have, and then see how much we can restore. Because clearly there was ground glass appearance also, and you showed in the echo that there was apical and mid anterior wall significant hypokinesis. But she's on dual antiplatelet, of course, and then see how she does. And Mario described this, RCA versus circumflex, which one is prominent and all that, but it doesn't have any real practical value, really.
Prognostically, if you get any patients with proximal LAD, then it should be more accuracy because outcomes are worse.
Yes, absolutely. But in the setting of anterior wall MI, the prox LAD we define by where is the septal coming from, right? This is a sky definition that before this septal perforator is prox. But the question is not that. Question is, what is the lesion where that, how much muscle is at jeopardy? I mean, who cares about septal perforator coming early or late? But the question is how much muscle as jeopardy depending on the location of the lesion. I go by that, and that makes more sense. But by definition, when we define the segments of the LAD, we call up to septal perforator as the prox, and then septal perforator to the bending of the knee type is the mid, and then distal following that. Yeah.
Arun, can you unshare?
Yeah.
Atahar bhai.
Thank you very much, Arun Aski, for your excellent presentation at the case discussion. So we have two more presentations from Rafiq sir and Chowdhury Hafiz. Sir.
Hafiz.
Hello, Rafiq sir.
Hafiz, should we start with Hafiz?
Okay, sir. Chowdhury Hafiz, right?
Can you see my slides now?
We see your screen. You have to double click on the ECG Basics.
Is it loading now?
Not yet.
Oh.
You see the long way off.
Oh, no? It doesn't go there?
Not yet.
Okay, let me share it again.
হাফিজ ভাইয়ের সাথে ইন্টারনেট একটু স্যার আর মনে হচ্ছে।
Can you see my screen now?
Yeah.
Yes, now.
Can you see the EKG now?
Yes.
All the slides are seen together.
Now
it.
Double click, please.
Okay, all right, good. Now you can see, right?
Yes.
Yeah. Okay, so this is a quick one. Just this morning, I got this EKG. A 64-year-old or something, a Turkish lady visiting Las Vegas, chest pain and came to the emergency room. History of hypertension, remote smoking, no other significant comorbidities, blood pressure like 180 over 100, and then this EKG. I just uploaded this when I was looking at Dr. Arun Maski's presentation, because this has relevance. So inferior ST elevation, and then there is precordial ST changes, right?
True.
So any guess? I mean, this patient was uncontrolled hypertension, EKG, and the clinical presentation consistent with STEMI, and we agreed to go to the cath lab. But just before going to the cath lab, any other thought? Chest X-ray normal, pulse ox good. We were good. It was like 52 minutes when we are in the cath lab from the initial door. So we are good time, 90 minutes. We have enough for the cricket lovers. We have 12 more overs and enough batsmen on hand. No rush. All predictable. We are going to win this 90 minutes dot to balloon. Everything good. And then trouble comes.
So what we are expecting, that is the LAD proximal lesion type 4 LAD.
Type 4 LAD, right? Okay. Anyone for inferior? There is inferior changes. You ignore that, or it is the Musky situation that there is a wraparound LAD giving the RCA problem. Just Professor Musky just showed. What do you think?
Yeah, that's what we think.
That may be a possibility.
That's a possibility.
Okay, so
type 4 LAD.
And another possibility, another possibility is sometimes some patients have large and long diagonal that goes from lateral to up to the inferior surface. And in that case, occlusion before that diagonal may give rise to this kind of ECG changes.
Okay, so let me walk back a little bit, because I always talk to Dr. Narula, who is my mentor, about this plaque rupture, plaque erosion, and activation of the coagulation cascade and the acute coronary syndrome. And he and Dr. Virmani from Armed Forces Institute of Pathology in Bethesda, Maryland, showed that all these macro vessel events happen in the proximal third or proximal half of the three major epicardial vessels. And therefore, if you get a diagonal STEMI, it's not common, it's rare. And that diagonal STEMI usually is a big diagonal. Sometimes we call it like dual LAD type, that both diagonals are dual LAD type. So diagonal or a PL branch STEMI is not that common, very, very rare. So this patient had a right coronary that is about 95% good flow, big, but anomalous circ coming from the right, then giving the ramus branch and also another branch almost going into the midway to the LAD, and then the couple of OM branch, and the LAD is about 1.52 vessel that suddenly stops at the mid segment. And I don't know whether the LAD is the culprit or the RCA is the culprit. I struggled to get a good view of the circumflex, and I see that there is no major stenosis in the anomalous circumflex. Question now. And now, this whole T20 cricket, which was almost in my hand, I'm losing time for the door to balloon. So I fixed the RCA. I called the surgeon because initially my gut feeling was that, what about the LAD? And the circ may have lesions. So I called them, but I took more pictures, and then I I realized that the circ is good. LAD may be ill-formed or maybe occluded, who knows. I fixed the RCA, control the blood pressure, check the EDP and see whether we need a balloon pump or not. And EDP was normal, patient pain got better. Luckily, we had a resident who speaks Turkish language. So I called her and then she was giving good feedback. And then we did not go after the LAD and we'll see how it goes. Because my gut feeling is that the LAD is probably ill-formed. The RCA is huge with the PDA and going almost to the meet into the apex of the LV. And I did a LV gram, and there is no anterior wall motion abnormality. Apical has some wall motion abnormality. So let's see how it goes. So let me go and show you. Yeah.
Can you see the angiograms?
Oh, I was trying. I will show you next time because I had to copy it, but and then the fellow was not helpful because the patient family came in and they were dragged by the family, so they could not make the CD for me. So I'll show you, I promise. Interesting. This is maybe 10 minutes. A 74-year-old with history of severe chest pain and dizziness and called 911. That was from about a couple of weeks ago when I wanted to show you, but my sound system was not working. So this is the EKG. What is? Can you read the options?
Yes.
STEMI, complete heart block and temporary wire and angiogram. STEMI and 4-1 block, atropine and lytics and cath if lytics fail, atropine IV and dopamine IV, and then do echo, cath and revascularize if troponin comes significantly positive, isoproterenol infusion and echo assessment. Now, these are not my made up options. These things were discussed on the night because I just wanted to tease the EP guys. An EP guy was on call and he said that you can do this, you can do that, and they confused the senior fellow. And the senior fellow did not call me like 6 o'clock in the morning. And he was telling me all these options. And I said, okay. So I just put those options for you. And they were worried about COVID, honestly. And they sent the COVID test. And because there are some so-called chest infiltrate, and one pulse ox showed pulse ox like 93. Everything else was like 95% or above. But that's what they are thinking about what to do. But I did not put that. I just wanted to see what do you think. And then we'll show you. Wadud, what do you think? We should take to the cath lab or give lytics or what? So you have cath lab on the way. Cath lab is okay, no problem. Logistically, no problem.
Option A would be my choice.
STEMI and block, temporary wire and cath.
Yeah.
Jamil?
Anyone else?
Hafiz bhai, STEMI, how can I say? ST elevation is not there.
Okay.
It is
We would argue.
it is acute coronary syndrome, no doubt, but not STEMI. I can say STEMI as even in lead 2, it's not more than half millimeter.
Actually,
Wadud, you agreed for STEMI. So what is your call?
Litri and APF showing some ST elevation. That's the point.
But it's not more than half millimeter.
Okay, so excellent point, and that's why I'm showing this. This half millimeter, 1 millimeter, all these are relevant when you are like, I call this the clinical presentation is iffy, but the EKG is florid, then go for it. If the clinical presentation is iffy, EKG is iffy, iffy plus iffy is more iffy. But here, the clinical presentation is overwhelmingly going in the direction of inferior. So this magnitude of half, and this is also relative. Look at the QRS complex in the 2-3 AVF. The relative amplitude is not that big. So all these guidelines writers, they give you guidelines. But if the clinically is convincing, this is inferior wall MI with the complete heart block. What you are waiting for? So that's my point, that should not be doing this isoproterenol business and then dopamine business, because the patient has chest pain and EKG changes. And look at the other, you know someone by the company it keeps. Look at the company, it is ST changes in the precordial leads, right? The precordial leads ST changes, there is no other explanation. This T wave is ugly and there is no intracranial hemorrhage or trauma or any other big issues to explain this. And the patient is having chest pain. So I told the fellow that do not do this kind of all night, this kind of problem, So I would not take anything other than STEMI and complete heart block, temporary wire and cath. These patients with the dopamine and isoproterenol and Rafiq Bhai can jump. I don't like them managed with this, the Zol pad standby, or even sometimes, percutaneous like the skin Zol pad with the patient jerking movement and paste, and then giving dopamine as backup. I think we need to forget those. Rafiq Bhai.
Sir, you have to unmute.
Yeah, I mean, those choices are ridiculous choices for me, because somebody comes with an episode of, no, simple as that. Somebody comes with a syncope because the patient fell down. And if you ask the patient in the history, did you remember falling down? Answer will be no. That means the patient had a syncope and complete heart block. Before you decide anything else, you put a temporary pacemaker in that patient. Number one. Second question, Hafiz's question would be cath or not. Yes, there is a subtle ST elevation. It's not very clear, but so cathing is not a bad, probably I will do that. But no question about temporary. I will not go for atropine transcutaneous spacer. Transcutaneous spacer, if the patient is in the ambulance, I will do the transcutaneous. But that's painful. If the patient is awake, I will not put a transcutaneous spacer. I'll just put a temporary pacemaker in this patient.
So by the time I was born, the total was 7.1. We did cath. But Wadud, stay on the case, because this is the cath. What do you do next? The coronaries are fine.
Coronaries are fine.
So I usually routinely do a ventriculogram proper, not like hand injection, proper ventriculogram when we have an issue like this. Remember that I call cath lab the Supreme Court of cardiology. You go through every data, echo, everything. But if you're not sure, decide whatever you need to do. And this is clearly a Takasubu pattern on the ventricular. So it was interesting because in the COVID time, this was classic Takasubu presenting with complete heart block, very rare in the literature. But here we go. And let me tell you another patient. It is important to recognize 54-year-old admitted with COVID. The previous patient actually lucky that COVID was negative. But regardless, as you know from the literature, that in the COVID time, the incidence of Takasubu has gone up, regardless of the presence of the COVID or not. This is a patient with COVID, 54-year-old, and EKG was like this in the beginning of his disease in the hospital. This is like day 3 of COVID. Sinus TAC, PVC, okay? And then Day 12, he developed respiratory decompensation, and EKG now is this. What do you do now? The options are on the right. And please actually commit yourself to this. So, Wadud, I actually argued very vigorously with the American College of Cardiology that if you have everything ready in the hospital, it just hurts me to give lytics in a place where there is cath, because for the PPE and for the protection of the healthcare workers, get the protection and do the cath. And now you know the SEC has changed. There is no lytics role in terms of alternative to cath when the cath is available. This is very important, because if we don't recognize, we'll be giving lytics unnecessarily and probably wrongly to some of the patients. So this patient had these ST elevations, and then question is whether you give lytics or do echo and assess and then avoid cath or cardiac cath, revascularize, or give lytics and cath if fails.
I would go for echo, because a ST elevation in anteroceptal, if it clearly involves V1 to V4, then there should be reciprocal changes in the inferior leads, ST depression, but it's not there.
Okay, so the
echo assessment and then decide about cath.
Right, but let me tell you about the reciprocal changes. The reciprocal changes is important to see, but in the absence of reciprocal changes, I would not disagree that this is not STEMI. But if you get it, you are good. If you get it, it's not a must. And in the guidelines, you also see that. And the other important thing is that what is the clinical presentation? Patient is profoundly hypoxic and decompensated because of that. Can that be an issue? And the hospital has cath lab and everything. So do what is best for the patient. That's my point to the fellows. So any vote on this? Can we take a vote?
Yes.
I think
Who can we?
Nothing is right or wrong here.
Just
Review poll, please.
Review, can we have a
yes,
poll?
sir. We are giving it, sir. Give us a few seconds, sir.
So by this time, Dr. Hafiz.
Yeah.
It is the day 12 ECG. What happened up to by day 1 to day 11?
So the patient is COVID, right? Patient has this COVID, that's chest infiltrating antibiotics. They did procalcitonin, and he is not ready to go home. So he was in the hospital. And then day 12, and we also do this as you are doing also, look at the inflammatory markers, D-dimer, and then see the chest infiltrate. And we also do high resolution CT to see the degree of hypoxia.
Answer, please.
Should we go for 30 seconds?
Yeah.
Okay.
Yes, 30 seconds.
So those are the things that was happening. And then at day 12, he likes, okay, so B, E, and C, cardiac cath and revascularization. Yeah. And as always, I am more with Wadud. But I was called in after the patient was in the cath lab, and they told me that patient already taken to the cath lab. So I said, okay. I did not agree because that could have been avoided. But I'm actually very against to give lytics in these patients, because some of the cardiologists even in Las Vegas argued that we should be giving lytics, but I am dead against that. Just to show you the cath was okay, and again, I did a ventriculogram. Any comment on this ventriculogram? Because you saw the last echo, and you are seeing this one. This is actually a variant of Takasubo. Compared to last one, which is classic, there is anterobasal, posterobasal hyperkinesis, and there is dyskinesia and aneurysm of the whole anteroapical and infraoapical wall. Here, look at that, the apex moves, apex actually moving well, and then the anterobasal, posterior basal moves, but the mid segment is dyskinetic. Mid segment. This is the mid segment variant of Takasubo, and we actually published from the echo also that what are the variants and how you can do from the echo and then define from the echo. And we gave the steroids and tocilizumab, and the patient did well. So, and I'll take 2 more, maybe 5 more minutes. Any questions on this so far?
No, excellent.
Patient did very well. So 71-year-old with history of cabbage, ischemic cardiomyopathy, admitted for fatigue and then found renal failure, and patient has an ICD. And this is for Rafiq Bhai. This patient went into this rhythm, and oh my God, I was challenged with these possibilities in the floor. The ICD did not go off. So this is not likely to be VT. Please don't laugh. The ATP therapy should always be able to terminate if programmed correctly. So I have scientists in my team. So they come up with all these propositions. So I'm just giving you the propositions, what the fellows and the residents argued with me. Give beta blocker IV, and then treat VT, proceed with cath. Okay. Let's take a vote. Rafiq Bhai, you want any comment before the vote? I know this is your favorite topic. Rafiq Bhai, maybe mute.
No, I'm fine. No, let's look at the answer, what the audience say.
Sorry, Rohit Bhai, okay. That's very good. So do you want to make a comment, Rafiq Bhai, what this other scientists?
This is stupid. This is ventricular tachycardia. I mean, there's no question about it. The question is, why did not the ICD treat it? Because the rate is 150. Probably it was not programmed right.
Yeah.
So that was the problem with this ICDs. Most ICDs, a lot of physicians program it single zone. And this is a VT of 150 base per, so it just didn't detect it.
And the ATP therapy was there, but ATP may not work, right?
No, that's not true. Question is, what was the rate cutoff for the VT detection?
Yeah.
This VT is 150.
Yeah.
So most of the ICDs are programmed around 170, 180. This is about 150. So probably it was below the rate cutoff. So he did not see it at all.
And actually, I showed you one case before that the ATP was 150. This was like a VT like 120, so it did not terminate. In this case, the ATP was actually a higher rate. But what I'm saying that ATP, even if it is programmed, it may not be 100% successful, or it may be programmed lower. And then this patient had a cabbage. I told you, this is the question that I have for Rafiq Bhai, that we did the cath and we found that there is a high-grade stenosis in the Lima to LAD beyond the anastomotic site. We fixed that. Okay. So then do you continue with any antiarrhythmic or just the ischemia? Anti-ischemic therapy is the best antiarrhythmic.
Well, the VT has nothing to do with this stenosis. VT happens simple as that. Because acute ischemia does not cause VT. Acute ischemia causes ventricular fibrillation. So this patient has a substrate. I mean, good that you did the cath and you fixed the vessel, which emanate. But it will totally depend on
So Rafiq bhai, I tell you what happened next. So I fixed this. We did not give any, amiodarone or anything. And our EP guy says, follow up with him, he will map it and do VT ablation.
If there is recurrent.
Yeah, if there is recurrent.
Yes.
I told him this. I said, I will follow up the patient and I will give it to if it recurs. But
Yes.
I have given him anti-ischemic therapy because this is monomorphic, probably scar related, right?
Yes, scar related VT. One of the things, you can make it worse by giving antiarrhythmic. Because what will happen, this VT is now 150. If you give them antiarrhythmic, it will become 120. And then you will not be able to program the ICD to such a low cutoff. I will not give antiarrhythmic, just follow this patient with a reprogrammed ICD.
Now, we always fight with you, Rafiq bhai, the EP guy is an interventionalist.
What about beta blocker?
Beta blocker is given, yeah, carvedilol, because of the part of the cardiomyopathy, we up-titrated that. But I always argue that, this polymorphic VT by rule is ischemia and monomorphic is scar. I get that. But many patients, after treating this monomorphic VT with ischemia treatment, they don't recur and we just sit tight.
What ischemic, which medicine?
Well, anti-ischemia means we fix the Lima to LAD.
Yes. Well, the whole point is that maybe this patient was getting VT once a year, once every 2 years.
Right.
So how do you know that this stenting preventing the VT? We don't know that. That's why it will be, and nobody has done a study on that. But the question would be, if there is a vessel to be stented, if you believe that area is ischemic, sure. It is worth angioplasting that patient. I mean, if somebody comes with VT, we always do that. But this is different rhythm now.
Yeah. Now, this is a 23-year-old with twin pregnancy, 39 weeks, and then had cardiac arrest. Ambulance went there, and the first thing they recorded is this. This is from the ambulance. This is like about 10 days ago. BP shown here, and then return of spontaneous circulation, and then patient got intubated. She had the following labs: abnormal liver function test, low platelets, hemoglobin 7.2. And then in the EKG in the emergency room was this, post-cardiac resuscitation EKG, STEMI activated from the emergency room. And we were called in. And now, what? And I give you these possibilities because this case, actually, I was involved from the beginning, not very beginning, but not too late. And I'll tell you what I did. The possibilities are STEMI activation, agree, and lytics. STEMI activation, agree, and proceed to cath lab with radiation protection, supportive care, and assess with echo, correction of metabolic derangement, OB consult, emergency C-section, and I can't read. Okay. And then correct the metabolic derangement. What do you think? The best course for the patient? Any comment from any faculty while we are working? Any question about the patients? So,
two, I do not agree at all.
What's that?
E, we can have some choice.
Okay. You can propose E, Wadud.
C and D. Yes, Khalid bhai.
This may be a HELP syndrome with SCAD.
Yes.
Okay. So health for sure, right?
Yeah.
Abnormal LFT, then patient had hypertension during pregnancy,
and
the low platelets, but hemoglobin is low. So
HELP syndrome.
I think first thing, in this situation, we all need to be clear that lytics is, I will fail and I will go after the fellow, if the fellow even says lytics. Thankfully, no one said that. Okay, that's good. And then this patient had C-section in the emergency room. I told them, do the C-section in the emergency room. And they looked at me and they were like, am I an idiot? But the high-risk OB, luckily, is a good doc. And I told them, so they did the emergency C-section in the OB. We corrected this metabolic derangement, a little bit of acidosis. I told them this is not a STEMI EKG, for sure. And then patient, I deactivated.
Can there be spontaneous dissection of the coronary artery as well?
That is possible, because if it is a STEMI, that's the only explanation, correct, Khalid?
Yeah.
Because in this patient, if you are thinking atherosclerotic plaque rupture, then I think will not look good. It has to be dissection. The question is, if it is aortic root looks good, and then the inferior situation is ST segment is rather depression, right?
Yeah.
All
And
right,
then-
Hafiz.
Yeah.
Talk to somebody like me and the young doctors that are listening.
Yeah.
Who does not do much cath. If you didn't give me the history of this ECG,
Yeah.
how am I going to read this ECG? There is ST elevation in lead AVR,
Yes.
ST elevation in lead V1,
Yeah.
and diffuse ST depression.
Yeah.
What will you call this? What
Okay,
will you
so
think?
if there is no history given, and
Yes.
this is one of the perfect examples that clinical context is important before we finally interpret. But when we don't have clinical info, we can always give differential. The differential is AVR ST elevation with ST segment depression in the 2-3 AVF, and as you said, minimal ST elevation in the V1. That is observation. Now, what are the possibilities that this scenario can present to us? One, it can be left main disease, but in the case of left main, the ST segment usually is not the shoulder down type in the lead AVR. Okay, so this goes against that, but we need to think about that this is a possibility. Other possibility, pulmonary embolism can give that. Profound hypoxia can give that. This ST segment elevation in the AVR. Profound acidosis and hypoxia can give that. So unless we know the clinical context, we should not jump. That this is definitely.
What was the final? What the patient?
Okay, so patient got the C-section, and then was admitted in the CCU, and then a day later, this is the EKG. All those changes gone, no cath done, and now the question is how you go from here.
What was the age of the patient?
The echo done, EF was like, patient age is 23, EF is like 45%. But remember, that was like on arrival, like within hours of arrival, the EF was little down.
Her first ECG was ventricular fibrillation or polymorphic VT?
This one?
No, the first one, the before that?
Polymorphic VT, yeah.
Polymorphic VT. Yeah. There is QT prolongation in this patient.
Absolutely brilliant. Yes, it is QT prolongation. And we thought that this is long QT related. But the question is, why the long QT, and is it acquired or is it congenital?
What about the last one, ECG? Last ECG?
Should I start the poll?
No.
I don't think that I have any. Okay. You showed the poll.
QT prolongation.
The poll was good, actually. Yeah, showed the poll, yeah. Rafiq bhai? So my point is that this long QT during this episode and then this EKG, are you convinced that QT is now still prolonged or little less?
QT is prolonged. But I would also ask for the level of potassium and magnesium. Look at V3. There is T wave U wave is there. These actually TU waves. Rafik sir,
So,
are these TU waves?
No, actually, this is the meeting point of the T and
P and P wave, no U wave is there.
I mean, it probably is bifid. I mean, if you look at V1, V2, it looks like U wave, but if you look at V6, it's different. So I think it's a TU complex.
TU complex.
Yeah,
yeah,
but
looks
pretty
like
long.
we actually called it TU, Ravik Bhai, and despite the correction of everything, that QT is still kind of prolonged.
Yeah, it still can be it can be congenital long QT syndrome that patient did not know.
So now what do we do? So I wanted to tell everybody that that how we do this. VT in structurally normal heart and VT in the structurally abnormal heart. And so in this
but Dr.
case,
Hafiz,
yeah.
sir, before that, actually, what is the explanation for the STT changes, that the ST elevation in AVR and the depression in all the leads now?
Post VT changes.
So one thing, Wadud, I have a comment on that. The post resuscitation, sometimes we do see changes, particularly when they use AP, and some ambulance crews, they use over enthusiastic AP, and we sometimes see the ST segment diffuse elevation. Here it is only AVR, and it can be because of that, but unlikely. And then we had these coexistent issues with metabolic derangements. Patient's potassium was like 3.1, but more importantly, patient was acidotic. pH was 7.1 or something like 7, something. That was corrected. And then hypotension, that was also got better. We gave the initial blood transfusion also following the C-section. And this EKG is after correcting all that. Coronary spasm possible, but we were very careful, as Khalid Mohsin mentioned, that can it be aortic, the coronary dissection in the pregnancy? That is also an important issue. Now, luckily, this was AVR ST elevation and then ST depression. The coronary dissection in the left main in the pregnancy, it is uniformly, actually can be fatal, but the most common is inferior. And I looked at the aortic root, and I was, the only way it can do the dissection, the aortic root shows some dilatation and some AI, which was not present. I lost another patient, like pregnancy-related death, and we did not cath, and patient died. We didn't have any time, and in the postmortem, it was shown that she had single coronary artery, single coronary. So, and I was feeling badly about this patient also, that if we cannot make her, once the baby is out, then it was all good. I was happy. Once the baby is out, it is all in my court. If I do cath, if I do anything, I'm okay, no worries. But the EF was good. Subsequently, correction of the metabolic derangements, all this EKG much better looking. And then the question is, in a VT, in a structurally normal heart, what is the long QT most likely? But the other possibilities are the CPVT, is also possible because of the initial polymorphic VT. So we don't know, and there is no family history of sudden cardiac death, but it is important to keep in your mind in the young patient to divide these categories into two, the structurally normal and structurally abnormal. And structurally normal goes into those on the right-hand panel that you are seeing. And I think Khalid Mohsin went through this nicely a few weeks ago. So the RV is borderline dilated, and this is another issue. When you have this Brugada or RVOT tachycardia, everybody sees RV dilated. Even the cardiac MR people call it like not sure. So I usually blind them. I don't tell them anything, and then tell them to read this cardiac MR independently. So what is the next move?
Rafiq sir, what will be your suggestion in such a case?
Well, I mean, we have to study first of all, RV, cardiac MRI, and then the decision have to be made whether the patient is an ICD or not. I mean, there is no question because there is nothing else to do. And the stakes are very, even though you are defining it as polymorphic VT, it is basically ventricular fibrillation. Because, yeah, anything that lasts more than, and the patient passes out, paramedics and shocks them. So it was a VF.
So we are planning to do all that as an outpatient, Rafiq Bhai. In the meantime, we gave the sub-Q ICD.
Thank you. Sir, do you want to share?
I think it's getting late today. 12:30, 10:30 p.m. your time.
It doesn't
Sorry,
matter.
Rafiq Bhai. Probably I took longer time.
It is 11:25.
11:25 there, right? No, I think it's late, right? So let's do it next time.
Such interesting case,
sir.
I could not resist myself to not to share, you know.
No, that's good.
Excellent case.
Rafiq sir,
Yeah.
something. In these cases, sometimes we get such a problem. Given that there is QT prolongation, and we do not have a reliable cardiac MRI facility where they can interpret the cardiac MRI quite well, what should we do? Should we go for ICD?
Well, let's make an assumption that you had a cardiac MRI and it's normal. So patient will still get an ICD. So no, yeah.
Yes,
So even if the cardiac MRI is positive, it gives us a diagnosis, arrhythmogenic right ventricular dysplasia. But a normal MRI in case of long QT syndrome, patient will get ICD anyway.
Yeah, that's why we give the ICD and then study as an outpatient. And this RV, borderline dilatation, you know, it will probably disappear, my thing. I think it's a long QT. Yeah. And then we are thinking about any role for genetic studies?
Yes.
And the family?
Definitely. All the family should be screened for this.
I think so. We are seeing something in this country as well. The physicians and the patients are getting well informed about the role of ICD, particularly when the ejection fraction is low. Many of our patients who are well off and the family is well educated, they go through the Google, think about what are the options available, and some of them are coming to us and asking, should we be implanting an ICD? That's very encouraging actually in this country because we did have that before. And another thing is we are seeing that this time for the last 6 months we are having this ECG program and also IPDI, the other programs. This has increased the level of expertise of the cardiologists and physicians as a whole. And I think as a whole there is a tendency to implant a pacemaker unnecessarily. That has been reduced to some extent. Atahar, what do you say?
True. I am absolutely agree with you.
That's my observation. So over the last 6 months, the tendency of suggestion that you have to have a pacemaker whenever you have a lower heart rate, even during sleep, that has been going down a little bit.
One of the things about long QT, you have to be careful who you implant the ICD, because in some variant, which are the adrenergic dependent, if you use the ICD, they can actually get multiple shocks. I mean, I have seen one young kid in Bangladesh, the ICD basically battery ran out in 2 days because every time she gets a shock, she gets more adrenergic drive and it caused more VT. So we have to be carefully choose this case.
And I have a simple rule for the fellows. If it is your problem, think about it. If it is patient's problem, then go aggressive. If it is, sometimes we discover things by EKG and this, and patient is completely asymptomatic. In those cases, I will request that you talk to the expert before you do anything. But if the patient has a dramatic presentation, patient has critical issues, then you need to probably put more efforts to circumvent the problem. But it is always important to share education and accountability. We are still accountable in what we do, because and in the US, Rafiq Bhai will jump in. For the ICD, we maintain the registry, the indication, and the payer. They'll go over that. For the PCI, we participate in the PCI registry, and then our data is public.
Athar bhai.
So we are going to conclude the session, sir. Actually,
Yes.
we are sorry that we cannot
Next time.
have the sir. Next week, sir. Actually, big congratulations to Chowdhury Hafiz for presenting such beautiful academic cases. It has opened some good lessons to us. Chowdhury Hafiz, thank you very much. And finally, sir, actually, Dr. Kaniz, Fatema, and Urun Maski also, they deserve the congratulation. We are happy to share their ECGs. And Dr. Khaled Mohsin, Abdul Al Jamil, then Dr. Asadul Zaman, congratulations to you all for participation for this discussion. Sir, next Saturday, we will have presenter Dr. Professor Abdul Kader Akondo and Aisha Kader. And in that day, actually, we'll wait for the rubric search presentation. Actually, our all participants actually wait for rubric search participation. It is today, time is short, so next week day. And so very happy. Thank you very much for your
myself. I congratulate myself because I was able to fix my audio system in the computer.
Right.
Good job.
It was 2 speakers, and I called Zoom, I called Razer, the company, and then finally I was able to. This was a simple thing. 2 speakers were in dyssynchrony. It was like Rohit issue. Synchronized speakers, and then it solved the problem.
Hafiz bhai, may I ask you a question about this that Turkish lady who had an stitching? Did she lose a lot of fortune in the casino of Las Vegas before?
I will find that out when I show you the film, because I'm not sure whether we did the right thing yet. So we are watching. The surgeons came in and asking, "Does he have a role to fix it?" I said, "What are you going to fix? I could not show you the LAD. You want to go and find the LAD? Be my guest." And then he ran away.
So, sir, we can conclude the session, sir. Thank you, everybody.
Thank you, sir. Assalamu alaikum, sir.
Thank you, Ribhu.
Thank you, sir.